I, for the whole of my practice, has lived in a registry environment, and I'd various times in my career have been on podiums supporting and not supporting the use of registry data, and I feel quite qualified to support each argument at this moment. I'm going to give you the highlights as I see it. We're going to talk about this in discussion about what is the role of registry data, and I think the summary is it's one of many sources that we should use. It's maybe no more or less important than any other form of data, and it will mean different things to different people at different times of their career. The thing to also remember, it tells us what happened, but it doesn't tell us why it happened. So with that, the introduction in terms of hips, we've got 400,000 primary hips, and pretty much every hip and every knee replacement in Australia has been captured on this registry since the year 2000. So the checking mechanism, it's pretty confident to say we're not missing many. So in terms of hip replacements, they're more than double than 13 years ago, and the mean age is 67 for interest. Now, in terms of the revision rate, we can say as a general rule on the Australian registry that at 16 years, if you have hip replacement, there's an 8.8% chance you'll have it revised during a 16-year period. The causes of revision, I've referred to that in question time previously, it's still loosening and lysis, dislocation, fracture and infection being the most common. And the fracture rate is higher if it is used in a neck of femur situation, if a total hip's used in a neck of femur situation, or if the anterior approach is used. So I'm going to just discuss a few risk factors: age and gender, the influence of primary pathology, surgeon experience, fixation, bearing surfaces. If you're struggling to stay awake, the last thing is the surgeon portal, which I think everyone here will find quite interesting. So you hang in there for that. In terms of age and gender, nothing surprising. Young females less than 50 are at the highest rate of revision, 11.4%. In fact, that is 16 years. And older females less than 75 are at the lowest risk of revision. In terms of surgeon experience, with experience classified as less than 3 years in practice, between 3 and 7, and 8 or more you're considered experience. No surprises there. The risk of revision is proportional to the experience category. So really what that means is if you're starting out in your practice, don't be in a hurry. Make sure you know your implant. Make sure that you have a comfortable team around you. I mean, that's fairly impressive data. Fixation. Cementless fixation has increased in its usage from 51% in Australia to 63% over that 13-year period. Hybrid fixation has remained fairly static, and there's been a decrease in all cemented fixation, so that is cemented top and bottom. In terms of results of fixation, for the first time, and this is very different to data I presented here 2 years ago, for the first time our registry deals only in fixation where advanced bearings are used, i.e. a hard on crosslink poly or a ceramic on ceramic. So conventional poly with either metal or poly or ceramic, and metal or metal are excluded. So I think that's fair to exclude the known poor performers. So in general, cementless fixation has a higher revision rate than cemented for the first 1.5 years, after which there is no difference. So in other words, cementless technology overall, generally, over the whole category, has a higher early failure rate. So you can see on that bottom graph, I've highlighted the start. So cementless fixation has a high early failure rate. Now, if we look at outcomes with respect to fixation, they vary with age and primary diagnosis and gender. So if you look at less than 65 years old, then there is no difference. Cementless, in terms of the stem, is the same. But if you're greater than 75, cemented and hybrid are less revised than cementless. There's a theme coming here, and I'm going to come with a summary. So why do cementless stems have a high early failure rate? Well, probably because 80% of us make one cementless stem try and work for every case, and some surgeons never use cement. So the conclusion from what we can take away from this registry data is we've got a variety of beasts that we deal with, and they all have slightly different femurs. So it's a bit fanciful to think that one implant is going to suit every femur. So like we have a variety of femurs, we need a variety of stems. In other words, stem optimisation, if you like, is the term. So that's valuable information we can learn from registry data. This is a particular challenge that I put to the registry, so this is not published in a report, but I asked the registry to do a special report comparing cemented and cementless femoral fixation in patients older than 75 years old, but only using the 3 best implants in each category. Okay, so we're trying to home in on and only surgeons who've done a certain volume. And what the conclusion is, for female patients older than 75 with a primary diagnosis of arthritis, the cemented stem philosophy is better than cementless. For male patients with arthritis greater than 75, cement fixation and cementless fixation is the same. But for all patients, both male and female, older than 75, with a fractured neck of femur, cemented femoral fixation philosophy is better. And it mirrors exactly what Dave was talking about in the very early information from the American Registry. Bearing surface, just quickly, cross-link poly is less revised than conventional. And at 16 years, the revision rate for total hips with cross-link poly is really quite low. And that works in, and we've proven that in the most successful acetabular shells. So whether they've got cross-link poly or conventional poly, the cross-link poly wins. And that's revision in all causes, particularly the most common one, loosening glasses and dislocation. Bearing surfaces. This is the first year that analysis on ceramics has been done on mixed ceramics. And when we talk about mixed ceramics, just think pink, okay? Prior to that, the zirconia and the mixed ceramics were all mixed. There's no difference between a metal on cross-link poly versus a ceramic, a pink ceramic on cross-link poly until after 3 years. And after 3 years, the ceramic on cross-link poly is less revised than the metal on cross-link poly. And there's a message, so I think if you see David's graphs on what's happening to the ceramic on poly, there's good registry justification for that. Ceramic on ceramic bearings with larger head are less revised than smaller heads, and I think this is an interesting piece of data, that the revision rate of a mixed ceramic on ceramic with a 36 head or greater compared with a ceramic on cross-link poly is about the same. Now that's at 10 years. So I think that's going to be very interesting to watch what happens down the track, because we know that ceramics don't get the lysis that polyethylene does. Neck of femur fracture, just quickly, bipolar is less revised than monoblock type implants, and cemented stems are less revised in both male and females with a primary diagnosis of neck of femur. Now, hang in there, I think this is a really important bit. I'm going a little over time, I'm catching up on my next talk. This is a new feature, and I think for this audience who are a little bit registry shy, I want to reassure you about some of the real value that we as individual surgeons can get from registry data. So it's a new feature, and it's an individual confidential surgeon report. It's presented as a funnel plot, and you can see your own performance compared to your colleagues. Now, this is like logging into your internet banking. Only you can log in. The bank knows when you log in, but none of your colleagues can see it. So this is the old-fashioned way. You know, you can see yourself compared to your colleagues, but not really as useful as this, as a funnel plot. So each black dot there is an individual surgeon. The green line you can see going horizontally is the expected or average, and it's matched for age and gender. The red line, if you're above the red line, you are 2 standard deviations outside what's expected. And the green diamond is the individual surgeon, so that's your own personal one. Now, this bloke here is having a bad time, okay? He's done about 100 implants, and overall, his revision for any reason is 4 or 5 times higher than expected. Now, you can also get this data which says, well, how do I compare to my colleagues within the first 2 years after implantation? Again, useful information. Are your failures happening early? You can say, well, why are they failing? And you can get your revision for dislocation. So you can get your overall revision rate, why they're being revised. You can look at revision for infection. Now, this bloke here, okay, having particularly bad time, we're talking 12 times the average. Let me go back there. So this surgeon may want to review sterilisation practices in his institution or his operating room. Useful information. So it's all confidential. The assumption is that most of us in this room are type A personalities with big egos, and will respond if we see we're not as good as our colleagues. I challenge anyone in this room to stick up their hand and say that if they saw their own individual results, saw they weren't as good as their colleagues, they would not respond. Same as logging into internet banking. In terms of outcomes or revisions, I will miss that, and I'll sum up. Younger surgeons, higher revision rates. Please remember that. Get a good team around you, take your time early in your career. Cement fixation is equal to cementless fixation in terms of longevity and revision rates in young patients. Cemented fixation is best in women over 75, and cement is best for both genders if the primary diagnosis is fractured neck or femur. Crosslink poly works, larger ceramic heads do better. Beware of minor revisions, and individual confidential surgeon reports are beneficial. Thank you.